Good
Good
afternoon.
afternoon, esteemed guests and distinguished faculty.
A very warm welcome to all of you. From the golden sands of Rajasthan to the cutting edge of robotic urology, RUFCON 2025.
Here,
Here at the majestic campus of AIMS Jodhpur,
we are your anchors, Dr. Manali Jain,
Dr. Ravi,
and over the next 3 days, we'll be your GPS to navigate the galaxy of surgical excellence that awaits you.
with the theme Advancing Precision in Urologic Surgery through Robotics and AI, RUFCON is not just a conference, it's a revolution in motion. And what better way to start than by extending our heartfelt welcome to the pioneers of this field.
RUFCON brings together a galaxy of international and national legends and the brightest minds of tomorrow, all geared up for the 3 days of live surgeries, immersive workshops, and exhilarating discussions. We thank all our attendees for being a part of this wonderful journey. We hope we find the sessions inspiring, the networking fruitful, and the experience unforgettable. I now invite the head of the Department of Urology, organizing chairperson, Professor Dr. A.S. Sandhu, to deliver the welcome address.
Thank you, Manali and Ravi. Good afternoon, ladies and gentlemen. It gives me immense pleasure to extend a very warm welcome to all of you to RUFCON 2025. It is an honor to host the distinguished faculty, fellows, residents, nurses, and technicians to this conference. This year, RUFCON is centered around a theme that is not only timely but also transformative for the future of urology. That is, advancing precision in urologic surgery through robotics and AI. This prestigious event is organized by the Department of Urology, AIMS Jodhpur, in association with Robotic Urology Forum and the Royal Urology Society of Rajasthan. Together, our mission is to provide a dynamic platform for innovation, collaboration, and the exchange of ideas that will shape the next era of robotic urological surgery. The conference spans 3 days, each designed to offer rich scientific engagement and practical learning. Day 1 will feature live robotic surgeries performed by leading experts from across the country. We also begin with inaugural ceremony today at 6:30 p.m., followed by panel discussions and workshop, setting the tone for the days ahead. Day 2 is filled with talks by international faculty, more live surgery, and deep dive into cutting-edge topics such as integration of AI in surgical planning. We also look forward to residents' paper presentations showcasing the next generation of urologists and nurses and technicians session. Day 3 will conclude the event with interactive sessions, engaging discussions, and a formal valedictory ceremony celebrating our shared learning and camaraderie. Beyond the academic program, we sincerely hope you enjoy your stay in the historic city of Jodhpur. The organizing committee has worked diligently to ensure your comfort throughout. Should you need any assistance whatsoever, please do not hesitate to reach out to our help desk numbers or to any member of the organizing team. We are here to support you. Once again, thank you for joining us and contributing to what promises to be an intellectually enriching and inspiring experience. Welcome to RUFCON 2025. Wishing you a very successful conference and a memorable stay in Jodhpur. Thank you.
Deeply thankful for your warm words, sir. Humbled and grateful. Without further ado,
Get ready to
clamp, connect, cut, and connect not just ureters but hearts and minds too. And remember, if anything goes off script, just blame it on the robots. Now that the scalpel of science sharpened and the robots are humming, let's move straight into our most awaited session, that is live surgeries.
Don't worry, these surgeries are live, but our patients are perfectly asleep and our surgeons fully awake, focused and caffeinated.
So let's begin with the live surgery coordinate session. I would like to call upon Dr. Vishnu Agarwal sir and Dr. Shashank Saini sir, who will be guiding us through an exciting array of live cases over the next 4 hours.
Good morning to all respected seniors, colleagues and my dear friends. So without further delay, we'll start the live operative surgeries. So we have some exciting surgery lined up for today. We have a nephron sparing surgery being performed by Raghunath sir at SMS Jaipur. We have the host Dr. Gautam Ram Chaudhary performing a posterior approach RARP, and we have Dr. Raghavan from Apollo Chennai who will be doing a neurosafe guided RARP. After that, Dr. Pranjal Modi will be demonstrating a robotic assisted kidney transplant. So I like to call my respected senior chairpersons, all the stalwarts from the field, Dr. D.V. Singh, Dr. Manav Suryavanshi sir, Dr. Mayank Mohan Agarwal sir, Dr. Rohit Kaushal sir, Dr. Saurabh Joshi sir and Dr. Suresh Rohlinia sir. So I request you to please come on the dais sir and have a seat. All the chairpersons, I hope everyone is there. Dr. D.V. Singh sir, Manav Suryavanshi sir, Mayank sir. In between these live surgeries, we have some semi-live surgery presentations. We have one semi-live from the States, Dr. Hariharan PG. He will be talking about single pole retroperitoneoscopy, partial nephrectomy. We'll be having Dr. Shanik Shah with us. He will be giving a presentation on bilateral onlay ureteric reconstruction. Then robotic assisted RARP, Dr. Deepak Jayaprakash, and robotic IVCT using Hugo Raz by Dr. Arjit Pradhan sir. So I'll request all these dignitaries to kindly upload their presentation so that we can start these semi-live presentation in between the live surgeries. And I think we are ready to go live. We have all the chairpersons on the dais.
We'll sit there if you don't mind.
No issue, sir. If you
Lights are very bright.
no problem, sir. From wherever you feel comfortable. I think it is more for the photos. It will look good if you are. Sure, sir. Sure. If that is a problem.
Yes, sir.
Dr. Karan? Dr. Karan?
Yes, sir. Yes, sir.
I think Raghunath sir is ready from SMS Jaipur. So I'll ask the AV people to connect to Raghunath sir. We can have the case presentations and maybe we'll start with Raghunath. I'll hand over to chairpersons to carry the proceedings. Thank you so much.
Please don't talk, otherwise I can't hear. Huh?
Hello? Dr. Raghunath, can you hear us?
Yes, yes, sir. Yes, sir. I can hear you.
I'm Dr. D.
Very good morning. Good evening. Good afternoon.
So, we would like to see you perform the surgery.
Just keep this clear. So everything is great here. Great hospitality at SMS Jaipur by Dr. Nachiket Das, Dr. Neeraj Agarwal. We are missing Dr. Shivam here.
Sir, excuse me. Sorry to interrupt in between, sir. I'll request the audiences to kindly come in the center row for a better experience. If all of you can come to the center rather than sitting apart, it will be better for like visually also. And I request all of you to please join our center row. Thank you.
Can we manage this screen here? Both screens are showing the surgeon console.
So can SMS Jaipur team just tell us about the case? Hello, Dr. Nachiket. Dr. Raghunath sir, are we audible?
Yes, sir. Can we start? Or would you like to?
Yes, sir.
know about this,
Sir,
this
please
patient,
start,
this
sir.
case.
I was requesting somebody there to
Present the case, sir.
To present the case, please.
No, we can't hear. We can't hear.
Dr. Raghu, this is Dr. Manav. Can you hear me?
Hi, Dr. Manav. Very good afternoon.
Good afternoon.
Yes, I can hear you very well.
Best wishes for an excellent demonstration that you are anyways going to put forth. Can we also have some know-how about the case that you are about to perform? Can someone
Yeah.
tell us about the case?
Yeah, yeah.
Sir, this is case of 36-year-old male patient. This is case of 36-year-old male patient who was evaluated for hematuria, and he was diagnosed to have a right renal lower pole mass, sir. He had hematuria 1 year ago, 2 episodes, sir, and he had no other urinary complaints. He had no comorbidities and is a chronic smoker and a non-alcoholic patient. He also has a history of left PCNL at outside hospital 1 month ago. His routine investigations were normal with creatinine of 0.87. Radiological investigations, ultrasound revealed a 4 centimeter mass in the lower pole of right kidney. His CT urography showed a 44 into 40 mm mass seen in the lower pole of right kidney, which was reaching till the calyx. This is the video image of showing the right renal lower pole mass. Mass is reaching till the calyx. These are the coronal sections. This is showing the mass of around 4 centimeters at the lower pole of right kidney. CT angiography was done which showed renal vein and IVC were normal with no thrombus inside them, and there was a single renal artery bilaterally. There was also a segmental branch supplying the lower pole. So now we are doing a robotic assisted partial nephrectomy in this case. Thank you, sir.
Can I speak? Dr. Manu?
Yes, Dr. Raghu, we are all ears.
Yeah. Can I comment on few things here?
Please do.
Yeah. So this is, it looks, I mean, what reporting says is 4 centimeter. This looks bigger than that. And we don't have no cortical phase of the CACT. And we don't have here, some limitations are there. Though they have a fantastic system here and fantastic hospitality. We don't have 3D images of this, and we don't have drop-in ultrasound probe. This is the limitations. Another small limitation from this morning, when I started working on this is, this ergonomics elbow support is not working at this point of time. Okay, so
What is not working? What supports?
The elbow support of this, it is not going up and down.
Oh, elbows.
Okay.
So it was going when we started the dissection. Now it is not going up and down, but we can manage it. So since we have, I don't know whether we have shown the CT images, the tumor is actually going and touching the lower calyx.
Yes, we agree.
Okay.
We have seen the
So I don't know whether you have seen that or not.
Yeah,
This
yes,
is
we
seen
have.
only in one image you could appreciate it. This is going and touching the lower calyx. So I may have to go almost like a polar nephrectomy because we don't have 3D, we don't have intra-op ultrasound. Otherwise, I could probably save more nephrons. So my emphasis here is not to save more nephrons. Of course, that will be there, but not to compromise on the functional outcomes, not to compromise on the oncological outcomes first. So with this, can we start? And here again, my strategy is conventionally, this is the right kidney, right lower pole tumor is there. There's only one artery and one vein. The relationship of the artery to the vein we don't know because if you have 3D, you know all those things. And generally, conventionally, we go just lateral to the IVC and we lift up everything, then we reach the hilum. Okay, here I am not doing that. There is one big advantage of lifting up everything and retracting the kidney laterally to reach the hilum. The big advantage is sometimes small renal arteries which drain directly supply the kidney, which will be missed even by the radiologists, expert radiologists, and even 3D can miss those things. So that is one big advantage if you completely dissect. Now in this case we could do that. For want of time, I am going directly to the hilum. One single artery, single vein is there. I have done a little bit of dissection and I will be dropping this completely. I will go inside the ureters, drop everything downward so that we can go and do partial nephrectomy directly. this is what is my plan. Any comments on that?
So what advantage, Dr. Raghu, you look forward to in this approach?
This is transperitoneal approach.
No, I meant when you said that you would otherwise routinely lift everything up and
Routinely we dissect lateral to the IVC, we lift up everything. In this case, even if I do this dissection, lifting up everything, again I have to drop all this ureter, all those things medially.
Okay.
So to avoid that one, I have adopted this
Okay, thank
in
you.
this particular case. Okay. So let us start dissecting and I am using right now 3 instruments. Port placement is standard and I have excellent assistant here. My senior most register fellow, Dr. Ankit is there, and today is his birthday. So he is going to assist me in the best possible way.
So birthday greetings to him and best wishes.
So this is one artery. So we can probably come back to you whenever you want, whenever you ask something.
So
Or
throughout
you can probably-
throughout the surgery you are going to use only these 3 instruments?
Mostly yes. Mostly yes.
So you would rather routinely use your needle holder as a retractor?
Generally yes, yes.
Okay, thank
We
you.
are used to this. In case if it is required, we can use progress, but it is probably not required in this case. Let's see. In case if it is required, definitely I would take.
And one more question to you, that you are doing so much of robotic surgeries, do you routinely use scoring systems for your kidney and nephron sparing surgeries, or you just go ahead on your hunch and experience?
No, I always score. I always use 3D for all partials. I would go for 3D, and all partials I would keep ultrasound. But that is not mandatory. That is not mandatory because we have a system and we have facilities. I use that. So this is the renal artery. I don't know whether it has been seen neatly in the CT film.
We could appreciate it very nicely.
Yeah,
They are good
yeah.
images.
I request all of you just to don't talk, otherwise I cannot hear them. Thank you.
Chairperson, can I ask a question?
Please do.
Yeah, Dr. Raghunath Ravi here.
Hi, Dr. Ravi.
Hi, sir.
Good afternoon.
So, not having an ultrasound, what are your comments on that? I mean, you said you would do it always, but it's not mandatory. So, for the audience, would you be able to elaborate?
If it is small cortical lesion, even if it is not there, I can manage. That's number one. And I sit with the radiologist. I plan out if ultrasound is not there. That's how I do. We discuss with the radiologist. Every frame by frame we go and understand. That's what we do.
Great, sir.
I think artery is dissected. I don't want to dissect too much. It is just sufficient for me to apply the clamp.
Hello.
Hello.
Good morning, sir. Dr. Saurabh here. Sir, in the history you told that PCNL has done 1 month before.
Yeah.
Left side. Okay. No, not the same side. Okay.
Yeah, PCNL has been done. I underwent PCNL 1 month before. Yeah. On the other side, not on this side.
That time growth was not picked up, I suppose.
Can I make a small request, please?
Yes, sir, please.
Can we have this screen divided exactly into the same halves so that we can see that RARP also in a bigger image?
So can the audiovisual team address this query, please?
Sir, the screen which we are communicating will be larger. So if when we will be at the RARP, then it will be larger, sir. So it's
Doctor,
In this screen, we are seeing on the screen they are showing the same.
yes, sir.
They are showing only NSS.
So can we see one prostate and one NSS, because only kidney is seen over here?
Okay, sir.
And when do you want us to
Everything-
switch to the other OR? Please let us know.
Sure.
Ankit?
Dr. Raghunath.
Yes, sir.
Yeah. So, as per the anatomy of artery, which was shared with us on the on the recon, there is a separate lower polar branch, very well seen, going towards the tumor. Would you consider selective clamping in this case, or would you still want to go ahead with the main artery clamping?
I would go with the main artery clamping. It is a big tumor and it is going up to the lower calyx. So I don't want to take that risk. Safety is more important. Can you just?
And at the same time, would you clamp the vein? Consider clamping the vein, or you just keep it dissected and?
I'll right side mostly I'll clamp the vein. Left side, most of the times I don't. And even sometimes, even if I clamp on the left side, I may open up. So it all depends on the situation. In this case, I am planning to clamp both artery and vein. So it's a big vein. I don't want to take control. Probably I can just manage just by this dissection. I don't have to go all round. Artery is controlled.
So, organizers, if it's okay, so can we just switch the
Mind sir,
audio?
can we bring in AIIMS Jodhpur, the host?
Yes, that's
is
what.
doing- yeah.
So can we do that?
Anju, you want Anju?
So while you're dissecting
team, please
the
bring
vein,
RARP.
we just toggle the audio to the AIIMS Jodhpur, so that we just know about that
Yeah,
case
yeah.
too, sir,
Please
while
go,
we
please go,
are seeing
please
your
go.
beautiful dissection, sir. So is AIIMS Jodhpur? Hello, AIIMS Jodhpur audio is available, Dr. Gautam. Can we switch the audio to AIIMS Jodhpur?
Dr. Gautam.
लेटर लो इसको रोटेट करो ये है ना
So please switch the screens. I believe the main screen should now be the prostate one.
या या
ये चेन्नई में क्यूगराज से कर रहे हैं RARP anterior approach and they are going to use that necrosite neurosite Raghavan.
हाँ सर
Dr. Gautam.
हाँ
Yeah, hi.
Am I on? Hello.
Yeah, this is Dr. Mayank from the auditorium.
Good afternoon, sir.
Good afternoon. And we have been watching you doing a silent dissection of the left-sided nodes and now the posterior approach. So can somebody tell us about the case?
I hope case has been presented, sir.
No,
Somebody should present the case.
Okay, Ankit, please present the case. Sir, after case presentation, I will be back. Go Dalu, Jutta.
Hello, am I audible, sir?
Yeah.
बोल दो
Clean कर दो.
सही क्या था? Hello.
Clean. Camera.
Hello.
Yes, case please.
Am I audible, sir?
Yes, sir.
Yeah, I'm Dr. Ankit, a final year resident in AIIMS Jodhpur. I'll be presenting the case capsule of robot-assisted laparoscopic radical prostatectomy. We have a patient of 66-year-old. He presented to us with bothersome lower tract symptoms for the past 5 years. He also has history of acute urinary retention 2.5 months ago. He has no metastatic symptoms. He also has history of TRP done on 20th of April 2025. We don't have any documents of this surgery and the reports which were available at that time. The HP came out to be adenocarcinoma of prostate with Gleason score of 4+3 and Gleason's grade group of 3 with no lymphovascular innervation and no perineal innervation. He underwent right open UNL hernia surgery also 15 years ago. He is a known smoker for the past 26 years and he has been abstaining from smoking for the past 6 months. He is not sexually active. On examination, he has ECOG score of 0. On examination, he has a inguinal hernia surgery scar On DRE, it is grade 2 prostate, which is hard, non-nodular. On the left side, the gland is asymmetrically enlarged and the lateral sulci are free, rectal mucosa is free. On investigations, he has hemoglobin of 14.9, his kidney function test is normal, urine culture is sterile, and has PSA of 7.30 at the time of presentation after TURP. On MPMR of prostate, the gland is 22.1 cc, and there is a Pyrites 5 lesion seen in the peripheral zone on the left side at basal, apical and mid zone, with ill-defined T2 hypointense lesion measuring 3 cross 2 cross 3.1 centimeter extending to the left transition zone. Here are the images. The first image is the T2 image. You can see the lesion in the anterolateral side. On DWI, we can also see the hyper-intense lesion, and they have also taken the dynamic contrast enhancement images and also EDC. These are the representative images. He also underwent CCT chest and abdomen, which showed 31 cc gland with a normal CT attenuation. There were no any metastatic lesions, and however there were few bilateral external iliac nodes which were sub-centimetric and maximum measuring 4 mm in the short axis diameter. This is the representative image of the CT. There were no mets, and coming to the pelvis.
Is there any specific reason for having done the CT scan?
Sir, the lesion was Pyrites 5, and also it comes under unfavorable intermediate risk, sir. That's why CT and bone scan both were done.
So you didn't
This is the
consider...
bone scanning
Okay,
images.
bone scan.
There were no definite scintigraphic evidence of skeletal metastasis. Diagnosis is a localized adenocarcinoma prostate, CT2B M0 with brilliancy score of 18%. The case was also discussed in multidisciplinary tumor board, and patient was given options of radical prostatectomy and radiation therapy with ADT. Patient opted for RARP. So we are planning for robotic radical prostatectomy.
So Dr. Gautam, with this background, what is your plan?
So the case is, I would say, locally advanced CA prostate, and disease is more on the left side. So post TURP status. So as you can see on the screen, let me introduce first our team anesthesia side lead by Dr. Kirandeep, and bedside the assistant is Dr. Shashank. He is third year resident MCH here, and Ramjivan is the Nikesh is the nursing officer assisting at the patient side, and the rest entire team is here. So
I thought greetings to all the unsung heroes of the case.
Sir?
I said hearty greetings to all the unsung heroes of the case.
Yes, sir. That's very important to introduce team. So
yeah.
Gautam,
sir,
do we have,
sir, good afternoon, sir.
Yeah, Shrenik here. Yeah, do you have a pre-operatively PSA before the TURP was done? Any idea, if at all, if it is available?
No, we don't have.
Okay, fair enough.
So to save the time, because we have two cases lined up today, so I have done the left side lymph node dissection. You can see beautiful anatomy, ureteric peristalsis. This is the obturator nerve, external vessels, obliterated umbilical ligament, and then entire node packet in a single piece has been removed. So you all agree that's sufficient?
So one question I would like, do you preserve the external iliacs on the left side of the artery and vein, or do you circumferentially bear the artery and vein?
No, I will not bear for the prostate, as I have done in this case. I will do this for the prostate, and be it a bladder, and skeletonization of the external iliac up to the ureteric bifurcation will be done.
Gautam,
sir,
what is the role of lymph node dissection? Like, this is a gentleman who has a 7 PSA, 3+4 or 4+3. So you, as a routine, what are your protocol? How do you really do the lymph nodes?
Sir, since it is locally advanced, if you see the MRI, the left side the disease is coming out of the prostate and involving the seminal vesicle, and you can see here evidently that left side seminal vesicle is not giving me very easy proceeding. So that's why, and further than Brigandy nomogram, it comes under the 18% risk of the metastasis. So we decided to go ahead with the lymph node dissection. That's the.
No,
and
perfect. Yeah, we just wanted to understand in today's era, I think what is your, how do you really go ahead? Yeah.
So, for the, my approach is the posterior first approach, conventional, what we all, I am doing since, 2019. So, 1 centimeter from the rectovesical pouch reflection, I will open this C-shaped incision, smiley incision, and then posterior approach is my preferred approach, you can see here. And I was little bit anterior, so I will show you. At entry, yeah, maybe because of this post URP setting, I was entering here, then I redefined my planes, and then now I am in the perfect plane, but left side seminal vesicle is, since disease mostly on the left side, so it looks bulky and angry. So no problem, I will go slowly. Left side vast difference I have cut, so I will be now comfortable in dissecting there. Yeah, this is the maybe because of post URP, but I will be slow here, no problem. And right side, I think looking to the radiology, I will be able to preserve neurovascular bundle neuralgia. Let's see.
May I request the chairperson, can you bring in the Chennai team also?
Sure, please. So,
Dr.
can we just flip over?
AB people kindly shift to team
Dr.
Chennai.
Gautam, Dr. Manav here will just leave you for some moment so that we can introduce the case from Chennai.
Sir, I will be doing, and please connect me.
We'll be watching you on the next screen, surely. We'll come back to you.
Thank you, sir.
Please
Thank
flip
you.
over to the Chennai team.
अरे भाई जब उधर बात कर रहे हैं तो थोड़ी शांत रहने के लिए बोलते
Dr. Raghavan. Dr. Raghavan. Dr. Raghavan. Hi, Manav here.
Good afternoon.
Are you audible? Good afternoon.
I hope I am audible.
You are with some echo. If it can be made a little better.
Switch off that, switch off Madhav's phone. Good afternoon and my greetings from Chennai. I'm so sorry I'm not there in Jodhpur. Today I'll do my best to be part of the team there and we will show some work that is happening with the Medtronic Hugo-Rast robot. The case today is a patient who is 57-year-old with a PSA of 6 and 7.2 on 2 different occasions. MRI showed only PIRADS 3, but the patient was very anxious, so we went ahead and did biopsy. The biopsy showed 1 core positive on the left side in the TZ zone. The rest of the biopsy was negative. We had a long discussion with the patient about active surveillance, RP and RT. His anxiety is so much that he wants a radical prostatectomy. So he has been listed for a radical prostatectomy, but because of the low volume, low risk disease, we are going to do a complete neurosafe technique, hopefully preserving every neurovascular bundle if possible. I'll do my best for that. Today with me is Dr. Pradeep, who is the anesthetist. If you can turn the camera. Hi Pradeep.
Hello sir. Dr. Raghavan, what is the Gleason score?
Hi, Dr. Pradeep.
Hi. That's Dr. Pradeep for you.
Hello.
He is my anesthetist for the last nearly 1,500 cases that we have done together. And with me is Dr. Madhav Tiwari, who is a consultant uro-oncologist now in Cancer Hospital. And we also have Nikita and Rashna and the bedside, and Tufail to assist, and Dr. Arunya, the anesthetist, who is busy with the phone. So, welcome. Pradeep, sorry, Madhav, do you want to take over? Or Pradeep, do you want to tell a few words? Yeah.
About anesthesia for robotics, as usual, it's a little different for robotic cases. Reasons being long duration cases, and position completely different from regular cases, what we do. So strapping the patient adequately and having adequate IV accesses and being ready for the duration, temperature, and stable hemodynamics throughout are absolutely essential for these kind of cases. More so when it comes to neuro-oncological cases, the associated comorbidities also poses a challenge.
यार आवाज कम करो, सुनाई नहीं दे रहा मेरे उधर उसको. प्रेस करो.
Thank you, Dr. Pradeep.
I will ask Dr. Madhav to give an update about the patient position, docking, because what you guys are very used to is a Da Vinci robot. Hugo is different. If you remember yourself as the old SI system, that's how the Da Vinci robot will get docked, as well as, that's how the Hugo Ross will get docked, and the port positions are very much similar to that. So I'm going to hand over to Madhav, who is going to show the ports, positions, docking, etc.
No round well for you all have to take conference. So this is the you have 4 arms, 1 on the right and 3 on the left. It shows green one weapons. So this will be a left hand and the rear arm, and that will be the camera, and the one on the right is the right hand. So the port configuration for is
Shashank? Yeah.
Hello? No, we can't hear you.
Hello, sir, can you hear me now?
Yeah, we can hear you now. You are showing the port positions.
Can you hear us?
Yes, yes.
Okay. So, good afternoon to everyone in Jodhpur. We hope you're having a great conference. So, this is the Hugo Ross system with 4 arms. We're going to be using 4 arms, 1 on the right and 3 on the left. Basically, the positioning is same as for with any other robotic system. The port position is very similar to the old SI system from Da Vinci. It is a lazy W. It has an 11 mm port in the middle for the camera. There are 3 8 mm ports in a W configuration for the other arms, and then we have 1 12 mm and 1 5 mm assistant ports. So the first arm that comes in is the camera arm. It comes in from the foot end.
Camera is in the supraumbilical position?
Yes, sir. Supraumbilical is the camera, yes. The camera and the reserve arm are supraumbilical. The right and left arms are at the level of the umbilicus.
What is the distance between the 2 lines that you have drawn?
It is just arbitrary, sir. You can, just based on experience, I would say 1 to 2 finger breadths.
No, but we have been, I have been operating on Hugo Ross in Delhi. I am Dr. D.V. Singh, and I have had the fortunate this thing to talk about with Dr. Raghavan earlier, before this robot was bought. So what is standard is, they say 5 centimeters distance between the 2. And if you make little more, it helps. So we are now making 6 centimeters, and the distance between the ports is at least 8 centimeter, preferably little more than that. That
yes,
helps.
between the ports is 8 centimeters, sir. So the a trick that I use is, I'll place the camera first. I'll go inside. I'll place the lateral most port first, and then I'll decide how far I can place the other tocas. So I'll always place the lateral most tocas first, and then adjust this accordingly.
Okay.
But even with 6 centimeters, it's fine. 8 centimeters, it's fine.
What is the size of the telescope?
Size of the telescope. This is an 11 mm 0 degree 11 mm port.
we are using a 0-degree camera and the 11 mm trocar for the camera. Others are all 8 mm.
So every time disposable ports are used, there are no metallic trocars in Hugo Ras?
They have metallic trocars. It is not available in India currently, but we can order it.
Okay, thank you.
Only the head is changed. The rest of it exactly like Da Vinci.
So,
So,
Dr.
our
Raghavan,
first
since this is a low risk case, would you still do a node dissection in this case? You're not audible clearly, sir.
Mike.
And what's the Gleason score of this patient in that one?
This is a 3+3 Gleason 3+3 ISUP grade group 3 with a PSA of 6. 3+3 grade group 1 with a PSA of 6.
So I believe you won't. You will skip the node dissection in this case.
We will not do a node dissection in this case. We have only done a few cases where we are not doing node dissections, but for a majority of cases we are still doing it. Maybe I think we have done 5 cases where low risk patients where we have had to do radical prostatectomy where we have not done node dissections.
Dr. Raghavan?
Yeah.
Dr. D.V. Singh, did you consider Redzius sparing in this particular case? Because here the grade is also very low and you could still spare nephrons, and Redzius sparing would be a better option. Of course, it is an individual choice.
Sir, I haven't done Redzius sparing at all. Sadly, one type of operation which I have not done is Redzius sparing.
Okay.
So what we do is a standard neurosafe where we do everything that happens in a Redzius sparing except that the Redzius space is open. You are right, sir. We can definitely do a Redzius sparing. This is an ideal case for that. It's just that I don't do Redzius sparing. That's all.
Right.
For this case, we are not going to do node dissection. The reason is it's too low risk. As Madhav said, so far in the many hundreds of prostatectomies we have done, about 4 patients we have not done node dissection. We tend to have an extremely low threshold to do node dissection, but this patient, benign feeling, MRI is favorable, biopsy is favorable, so we are going to skip node dissection. Yes, sir.
So, Dr. Raghavan, just a comment from you as you start. In your experience that you have used so much of Hugo Ras, Dr. Manav here. So, would a Redzius sparing be anyway different from Da Vinci, or would there be some struggle, or you expect it to be a routine cakewalk?
I wouldn't say Redzius will be very easy with the Hugo Ras. Manav, you would have used SI.
I have, yes.
It's very similar to that. The arms are a bit more bulky, and the length of the arms are longer, and therefore when you are going to do Redzius sparing as a complete procedure, I suspect it will be a bit of a struggle with Hugo Ras. Not that it's not possible, it will be a bit of a struggle. We have experimented everything in Hugo Ras, including cystectomy and neobladder as well. So we have got around it. The only 2 things we haven't tried is retrobectoral partial and Redzius sparing. That's the only 2 things we have not tried it. But I personally feel it will be a bit of a struggle, so couldn't be bothered with it, that's all.
So, best wishes for this case, please start.
Thank you. Give us a few minutes while you guys see the other screens. We will get the case started, we'll get the bladder drop, and then I'll catch up with you guys.
We'll toggle to the next OT because Dr. Raghu seems to be waiting for us, okay?
Yes.
Thank you.
Yes.
We'll come back.
Thank you all.
Sir, should we go to Dr. Raghu's OT? I think please switch to the nephron sparing Dr. Raghu's OT from SMS Jaipur.
Dr. Manav?
Hello, Dr. Raghu?
Yeah, Manav, this is Nachiket here.
Hi, Nachiket.
So, Dr. Raghunath wanted to share something, so I am handing over the mic to him now.
Yeah.
So he wants to show some info.
Manav,
we are all ears, sir.
All of you are aware of these things. What is called port hub. Since the lower port tumor, I was unable to lift the way I am doing it right now. So I changed the ports. My needle driver, instead of 1, it came to 4. Okay, this is called port hop. This is for the juniors, where you can exchange the ports in DaVinci X system and XI system. I changed that, so I am working with 1 and 3 ports instead of 4. Okay, so that I could go all round. I could dissect, since I am going to my, the line of incision or whatever cut will be here, so I have to dissect it well in advance, otherwise I spend more time, more ischemia time. So I am just dissecting all these things even posteriorly. Many people may not do it, but I always do it. See, posteriorly completely we have done it. We know where to cut it. Of course, we don't have 3D and we don't have ultrasound. Ultrasound would have been a great help. Now it is not possible. So port help, I could go here. See, I have done all this dissection by changing the port. Okay, can you make out that?
Yes, we can appreciate. It's very innovative.
Yeah. Okay, so I'm just manipulating little bit. Needle driver is a very robust instrument. You should be extremely careful while using this. And to go behind, sometimes I use 30 up. 30 up will be very useful. Port hop or 30 up, you can understand many things. See? So I'm going almost virtually all round the tumor.
Hello, Dr. Raghunath, Dr. Saurabh here. Sir, you can use transvaginal probe to mark if you have no facility of ultrasound. We are regularly using it and it is very beneficial.
I'm sorry, I can't hear you.
Sir, you can use transvaginal ultrasound probe by a small incision to mark the tumor. If you don't have
Transvaginal ultrasound probe.
Yes, transvaginal ultrasound probe. It is easily available in every hospital.
I don't know whether they have this or not. I'm not sure
you
about
can
that.
mark beautifully with this, and in fact, endophytic tumor, it's very beneficial.
It's a great idea.
Yes, it's a big tumor.
solution.
That's why.
I don't think we have that, so I'm just dropping it little bit so that I can go all round. So if it is possible, try to do all this dissection completely before clamping, so that you don't have to waste time for doing this dissection. That's it. We can probably go to other theatres.
Yeah. So can we switch to Dr.
And always see, you should be cognizant about this rubbing over the tumor. It's very, very important. You'll be focusing here, you'll be doing, but you may be pressing the tumor. If it is a cystic one, probably you can rupture the cyst. So you should be cognizant about that.
I just want to
Make a comment. So this is Nachiket Vyas. Am I audible inside the?
Yeah, Nachiket.
Yeah, so sorry we do not have a robotic ultrasound over here, but from what I hear, that Dr. Sandhu and Dr. Gautam Chaudhary, they have promised to buy SMS and ultrasound from the savings of the conference.
So that's going to be huge amount of saving. I can see that. So can we just for the moment switch the audio to that AIMS Jodhpur, Dr. Gautam? Yeah, Gautam.
Hi,
Dr.
sir.
Gautam?
Sir.
Yeah. So can you just explain, because we've been away for some time, just can you explain what all have you done?
I will show you. I have dissected on the right side the seminal vesicle and I applied clips. Probably I was thinking to have the nerve sparing on the right side, so I didn't use cautery there. Left side, definitely it's a bulky disease and probably involving the SV, so I used lot of cautery. But both side I could be dissect both SVs, and posteriorly I am facing post URP. Some you can see the rectal fibers here, so I am I am not very.
So have you opened the Gerota's posterior layer here? No, I don't think you have. I'm sorry, Denelius fascia. I'm sorry,
sir. And probably I have reached to the apex, like pubo-urethralis. I am thinking this is the pubo-urethralis. Let's see. So I want to stop here because a small oozing happened there, and I can do it later.
Yeah.
So now I will first is the posterior. Then after cutting both as seminal vesicle at the lateral end of the SV on both sides. Now the attachment is between the bladder base, the trigone, and the SV. So I will be dissecting here.
So
before
what's the
I
key in
go to the
what's the
anteday.
key in avoiding
Dropping the bladder.
Yeah, Dr. Gautam. So what's the key in
Your
avoiding?
voice is very low.
Okay. So is it better now?
Yes, sir. Bit better. Bit better.
Yeah. So what is the key in avoiding going through the tumor on the seminal vesicle infiltrated side? So how do you make sure that you don't get into the tumor while dissecting the seminal vesicle on the left
Okay,
side?
while handling SV,
Yes.
So while handling the SV, usually rupture happen in the left, this right side, which was healthy because probably this left side is involved by tumor, so they don't have they are dried up or kind of infiltration. They usually do not rupture. The tumor still is maybe there, but this clear fluid, seminal fluid is okay, no problem. So I have dissected here, and I am not going too deep here. I am not want to keep very much dissection into the bladder neck because already TRP has done. So I don't know how TRP till what extent and how much the prostatic tissue removed here. So I don't want to give the positive margin. I may be staying bit back, posterior to the bladder. So I am happy with the opening large bladder neck rather than going into the prostate.
Dr. Gautam, have you done a cystoscopy?
Cystoscopy, no, sir.
That would have helped, I suppose.
For ureteric orifice, you are saying, sir?
I mean, to knowing the neck, how deep it is.
So post TRP in my early career, I used to do, and then I was comfortable, so I am not doing. But yes, your point is very valid. That this makes you very comfortable that how the bladder neck would be, how far the ureteric orifices are. So definitely, that's how I started. But I don't know. Probably cystoscopy would have been a help.
No, that is because you were raising a concern. That's why I asked the question.
Sir, your voice is very low.
Okay. I think so.
Sir, now clear. Now better. Sir, say it again.
So sir is saying that because you raised a concern, that's why he asked a question to you.
Yes, it's a very valid concern, and I am afraid of also because bladder neck opening and size of the bladder neck is not in my hand now. Let's see.
Sir, can we go to Dr.
So can we go to the Chennai audio to Chennai?
I think Dr. Yuvraj and Dr. Raghunath is waiting for clamping. Maybe chairperson,
Yeah.
we can shift to
Okay,
Raghunath, sir.
okay. We thought they were still dissecting. So let's go to Dr. Raghunath. SMS Jaipur.
Yeah, AV team shift to SMS Jaipur, please. Yeah.
Yeah, Dr. Raghunath sir.
Yes, sir.
Yes, sir. So can you
we have done this much. Now marking, we don't have any landmarks here. I will do what is called cognitive marking. I have seen the CT, I have seen the, angios and all. So based on that, I have some impression. That impression may not be the accurate one. And because of that, and because it's going up to the calyx, I may remove more nephrons. Pardon me for that, but I don't want to give a positive margin. That's my plan right now. You can suggest me looking at that. Maybe I may be cutting little here, somewhere here. It is like it's a big defect will be there. Any suggestions on that? Because this tumor,
actually, and you're right, sir, because
going up to here.
Yes, because you're right. It's a very nodular kind of, not a very very smooth.
Generally, we don't see this kind of tumors, no?
Yes.
One nodule is here. This may be cystic, and this is nodular.
Yes. So
and
you will have to take
a couple of cysts are there in this. You can make out.
Yes.
So what I have done so far is I have dissected all round. This dissection is very important because when you start cutting now, this fat will be still attached with this. It will come in the way of rhinorrhaphy. You don't know where exactly is the capsule, how much of depth you have to take, how much of margin you have to take during rhinorrhaphy, you don't know. So because of that, I always make sure if it is possible, you have to go all round. You can, I'll just turn the camera to cut it up. you can make out. There is some, this Da Vinci is giving some problem. Ask Da Vinci guy to stay here. This is the third time it's giving this problem. I'm sorry, there is some issue, technical issue. Yeah.
So can you tell sir what is the technical issue happening?
It's not talking.
Mano?
Yes, we can hear you, Dr. Raghu.
Ravi, I've done this dissection completely behind. You see, this is also tumor. Can you appreciate this? This is also tumor.
Yes, absolutely.
Yes, we can.
So I cannot afford to go and cut here only. I will be going here.
Yes.
This is tumor. You can make out this tumor. This is going up to there. So probably my marking will be somewhere here.
Correct.
Do you agree with me?
Yes,
we agree.
Perfect.
Yes.
This is, I don't know, what do you call this? Cognitive marking. I don't know.
Based on the CT impression that you have, and if you mobilize the whole kidney and you are able to see, so you have some idea. So based on that idea and the absence, so if suppose you do enter the tumor at some point of time, you can do course correction after that.
Raghu?
Yes.
Yuvraj here. So I think posteriorly the marking is perfect.
Can you be a bit louder?
Posteriorly the marking looks okay. Anteriorly you can little bit save the parenchyma and make a like a cone shape, rather than
See here actually, if you see the CT,
you just press it, you can see whether it is
the tumor is coming here only. Tumor is coming.
No, it is
here.
inside. What I'm saying is parenchyma, little bit you can dig it out rather than cutting this
Yeah. Let me try to do that.
Go little
because
bit.
we don't have ultrasound.
Yeah,
I'm going probably may remove few hundred nephrons more.
No, that is fine, and this is important because many institutes may not have sonography, so they have to learn this also. This is good that you are doing this way.
Yeah. Any other suggestions?
So I think Dr.
I can make out this tumor is coming up to here, so that's why my marking is somewhere here.
Yeah, that is perfect.
I think you're fine.
Dr. Raghu, can I just make a comment over here?
Suggestions, advice, all are welcome.
I think making a prefixed notion about marking may actually hamper you from a course correction. So you just have an idea, you clamp it, you dig at one place in anteriorly, looking at the plasticity of the tissue by touching with the backside of the scissor, and the plasticity, once you go 1 centimeter inside, from there on you can course correct and keep on making the markings.
Dr. Ajay Sharma here.
Because I don't have exact mental picture.
I agree. Dr. Ajay wants to make a comment.
Yeah, Raghu.
I am erring more on the side of removing little more nephrons. I don't want to
Agreed. Absolutely agreed. Absolutely agreed. Dr. Ajay wants to make a comment.
Yeah, please.
Actually, once you open the kidney at one place, the tumor itself will guide you very well.
Can you increase the?
Can you hear?
So Dr. Ajay is saying that in case you open the kidney at one place after clamping, the tumor itself will start guiding you with its contour.
Yes, and then you can actually identify the proper gray parenchyma, and then you just keep following, and you can actually do it completely without cutting horizontally. You don't have to do a guillotine kind of dissection.
But I think in this case, sir, you are doing all right, because this is a nodular tumor on the surface. It's not a smooth spherical tumor. So it's better to have a little bit more extra parenchyma cut rather than going into the tumor and then course correcting. So I think your markings are quite good.
Hello. So I can't do any marking on one side, so I will just go with this like a bulletin. I do it. That's what.
So Dr. P. Singh wants to make a comment. Please go ahead, sir.
If I have ultrasound, probably my marking may be here. I may be going inwards like a concave defect I could have created. Here I don't want to take that risk.
Dr. Raghu? Yeah, Dr. P.P. Singh this side. Good morning.
Good morning, Dr. P.P. How are you?
I'm good. No, I was asking you, in this situation, because we do not have an ultrasound, we understand, would a firefly technique help give a small dose of indigo carmine, and that will delineate the tumor, cut the parenchyma a little lower, as Dr. Yuvraja said, and then you will be able to see the tumor well. Give a low dose indigo carmine.
Your point is very well taken. I'm telling you, if I have an ultrasound, probably I would have started from here. I would have started from here, I would have saved some nephrons. In this case, I don't want to take a risk, because if you start from here, see, the tumor is coming up to here.
Yes, that is very well appreciated.
You can actually appreciate.
Yes, yes.
Dr. Raghu, your point is well taken. Please proceed as per your technique.
Thank you.
Can I make a suggestion here?
Please do so.
Yeah, Dr. Saurabh has mentioned about use of rectal probe.
Transvaginal, sir.
Yes,
transvaginal probe is better.
Probe, whatever
Yes.
it is. So how do you use it from your?
We can use it one of the port, 12 mm port, and from the subcostal, and it mark the kidney very well. And we did 7 to 8 cases, because we also don't have
Only
abdominal
anteriorly you
ultrasound.
can mark. Maybe you have to flip the kidney to mark. the
Yes,
posterior.
you have to mobilize the kidney. Then posteriorly you can manage it to mark.
I see those everything is ready.
This is Dr. Nachiket Vyas.
Yeah, come on. You ready?
Can you hear me?
Anesthesia is ready.
Yes, we can.
The person who is
So actually what happened is that when we were sending the angiography films to Raghunath sir, so the protocol over here that is used by the radiology department is slightly different, and the reconstruction that he wanted, as we all know, I mean, we're lucky to have him over here to operate this case, but however he weren't able to simulate the reconstructions and the angiography films that he has inside his institute. So that's why that is one of the lacuna of the, he was saying that he cannot make a mental picture about how endophytic the tumor is. So for that I tried my best to give him simulated pictures of which are very similar to his department, but yes, I think that is one of the reasons why he's taking slightly more margin, because he's not able to make a mental picture about the endophytic component.
Nachiket, can you please show us once the CT also to all of us?
Yes, we'll try to do that. For that, we'll have to slightly move the camera or something. If I'm able to do it right now, because we moved the the laptop out of the OT.
Okay. Yeah, if it is difficult, it is fine. Don't worry.
Yeah. So we'll try to do that, Manav, and if we're able to, then we'll share it.
Oh, that was Dr. Shrenik Shah. That's okay. Please go ahead.
Okay, right, Shrenik Shah, sir.
Just check.
पता चलेगा ना तो क्या प्लान है
नहीं put a clip अंदर clip नहीं लगाए हैं
दो बार ये दो पहले हम यूज करेंगे ठीक है
we have to tell them पहले inner layer prove out करना है
chairpersons can be changed to other OT by while they are getting ready to clamp.
Take another ball,
put
it in the water.
So I think can we ask Dr. Raghavan what is he doing now?
Yes, shift to Apollo
Chennai OT, Chennai please.
I'm okay now.
Dr. Raghavan?
Mayank,
Yes, sir.
sorry to interrupt you, Mayank sir. Yeah. Sorry to interrupt you. I think it's time to give a breather to our chairpersons. Let's have a glass of water and some lunch. For all the attendees, lunch is a working lunch today. So all of whosoever is feeling hungry, I think most of us can have a taste of Jodhpur cuisine, and we'll call upon the second set of chairpersons now.
Yeah, before we leave,
yes.
at least we'll ask Dr. Raghavan. So
Yes, sir.
can you please describe what you're doing?
Hi, can you hear me?
Yeah.
So what we have done so far is ports, dock, down the bladder. So we keep tools of the bladder attached to the top, and then I have a scissors on the right hand, left hand has fenestrated bipolar, and a carrier on the third hand, because the progress here is a carrier in Pugaras. I've done the departed the prostate. This is the definition of the prostate, as you can see. We have which is the bladder neck here, and the puboprostatic and probably the lateral neurovascular bundle is here on either way. So what I do is I create a plane here to get my definitions of the neurovascular bundle, then bladder neck, and then go down and then power the nerves all around. That's how I do.
So Dr.
Yes, sir.
Can I interject, Dr. Raghavan? Why do you keep the bladder attached at the superior most end?
See, me and Madhav keep experimenting hundreds of things, and this is one of our experiments. I'm not sure whether it helps in continence, but even if it is contributing 0.3%, I'm okay with it.
So you're trying to achieve some better continence with this maneuver.
Yeah, that's all. Also, if I can chip in, can you hear me, sir? Yeah, please. Can you hear me? Yeah, can you just give the
Before our chairpersons leave the dais, I will kindly request all the chairpersons to kindly come in the center. We can have a group photograph, please.
Can you, Manav, can you hear Madhav speaking?
Yes, we can. We can. Yes.
Yeah, Madhav, please. So it also keeps the bladder out of the way for the assistants.
Okay. Thank you.
It's not always down there, not in the way. We find it easier for the assistant. He's not constantly hitting the bladder.
Okay.
That's the only reason. We don't know if it is actually working.
Because you know, even if you detach it completely, once the pneumo goes away, the bladder is anatomically going to stick to the anterior abdominal wall anyhow. Because if you go second time into such cases for any further surgeries, you will see the bladder exactly in the same place where you dissected it.
Yes, but one of the reasons is that it keeps the bladder retracted and...
I agree. That's a valid point. You're making your life easier. It's a smart technique.
Yes.
Thank you.
See, Manav, joy of having youngsters with you. They give smart ideas.
Absolutely. Thanks.
I thank the first set of chairpersons for their valuable input and chairing this session. May I request all of you to come to the center. We can have a group photograph, please. At some stage, I will show the present console of the Hugo RAS. Whenever you guys are free, then I will show the Hugo RAS console. Thank you all, sirs. Thank you so much. Now I will like to call upon the second set of chairpersons for our session from 2 to 3 o'clock. I'd like to have Dr. Jayant, if he is here, Dr. Minal Pava, sir, Dr. Samit Chaturvedi, sir, is he here, sir? Dr. Samit Chaturvedi, sir, Dr. Shailendra Goyal, sir, is he here? Not there. Dr. Shri Vatsayan, sir, please come to the dais. Dr. Vamshi Krishna P. Dr. Vamshi, sir. May I request Dr. P.P. Singh, sir, to please chair the session for us, sir. Thank you, sir. And Dr. Yuvraja, sir, can you please chair the session, sir? Next one, sir. Okay. Thank you, sir. Maybe Dr. Ravi sir can come, sir, or will you go to the OT? Okay. Then we will have 4 chairpersons for this session. I will like you to please take your seats, and we can. I ask Dr. Vamsi to please carry on the session, sir, please.
Okay. DVC. Yep.
I'll just do it.
Hello. Raghavan sir, Dr. Vamsi here.
Hi Vamsi, hi, how are you?
I am good, sir. Good demonstration and nice different technique we are seeing today from you. Having that bladder drop laterally, not fully also. Yeah, that tag you have attached at the urachus.
Yeah, well, thanks to Madhav who decided to do that way.
Okay.
So all credit goes to him as well. Vamsi, you are using Hugo RAS, so for the people who are not using Hugo RAS, can the camera show me here? So we have a 3D screen with the 3D glasses, at least that's what I am using. I believe that viewer forms are coming through. This is the surgeon console. We have a tile pro here or a tile here, which we can choose the instrument that we want to choose here. And I have the monopolar on the right side, the bipolar on the left side, and carrier on the left side as well. Well, of course, you can choose it any way you want to choose it. You have an option to increase or decrease the contrast, increase or decrease the brightness here. As I said, many of this system is very similar to the DaVinci SI system that we used to have the opportunity to increase or decrease the contrast. The vision that we get with the camera is very similar to DaVinci SI system than the DaVinci XI system. But having said that, it is not very difficult to move it operations between the two systems. It's not very difficult. We have done it many times where we do one in the morning and the other in the afternoon. It's a very, you can sit straight and it has a 3D vision and you are always in communication with your team. It is not that you are sitting in a closed space. So that is those are the advantages of HugoRAS.
Sir, good afternoon. Srivatsa here, sir. Raghavan, sir.
Hi, Srivatsa.
Sir, for a person like you who has extensively used both the systems, that's the HugoRAS and now the DaVinci and now the HugoRAS, can you tell us your opinion on I'll just ask you 2-3 bits, sir. The console, what do you feel is more comfortable and more ergonomic? The one with the HugoRAS open or?
You will sit straight and your neck is very straight. Yeah? You have a big screen, you are not looking at a very tiny closed vision. And those are the advantages of HugoRAS compared to the DaVinci.
And your hand control, your hand control, sir?
It's perfect. It's absolutely as good as DaVinci, if not slightly better. It's more smoother than DaVinci many a times.
Okay.
The only disadvantage, you should ask me what the disadvantage. The disadvantage of HugoRAS is that it's a laparoscopic 3D vision. It's not an immersive 3D vision as you get in DaVinci. In DaVinci you get an immersive 3D vision. Whereas in HugoRAS you get, or for that matter in CMR or any of the SS Mantra, you get a laparoscopic 3D vision. So it's slightly like a mildly tunnel vision, like a tunnel, rather than a immersive vision. So you should be able to understand and adjust yourself for that. That's all.
Dr. Raghavan, PP Singh this side. Now coming to this 3D vision, so is the 3D vision available to the assistant also in HugoRAS or is it only to you?
I never understood why it is not available to the assistant, sir, but it is not available to the assistant.
Now, as I understand, you are doing a complete nerve sparing surgery. So in your nerve sparing technique, do you divide the endopelvic fascia completely laterally or you just leave it alone there? I am seeing on the right side you have divided it a little bit.
No, sir, they are not divided.
Yes.
The endopelvic fascia is still intact.
It is not divided.
I have removed all the fat.
Yes.
I have removed the fat so that I can get the definitions. But the endopelvic fascia is intact.
Intact. So we till the end we will not divide even the puboprostatic ligaments.
No, sir, we don't do this, sir.
That is
so what happens is you go like this, you create a hood, very similar to Ash Tiwari, Yuvaraja sir technique, where you create a hood there and just scoop the prostate out and come out.
Yes, correct. Sir, maybe we, if you can excuse us for a minute, we want to go to Dr. Raghu. He is waiting for us.
Yes, sir, please. Please carry on.
We are seeing you, will join you back.
Yeah, sure.
So can we shift to Dr. Raghu now? Dr. Raghu? Sorry, we can't hear you. You are not audible. Hello? Audio guy?
Yeah, please. Raghu sir, please. Now we are muted.
Hello? Can you hear me?
We are hearing you, sir. It is audible.
See, before clamping, we have to follow certain rules. This is very important, particularly for youngsters and even probably seniors also. We always rehearse with the team which suture material I am going to use, which clamps I am going to use. We have Scanlan clamps. My plan is one curved clamp and one straight clamp to the artery. 2 clamps to the artery. 2 are not generally required, but we are going to use 2. And 1 to the vein. Particularly on the right side, I always clip vein. On the left side, sometimes we don't have to. And sometimes it can be detrimental. If you clamp it, if vein is filling, despite of clamping the artery, sometimes by removing the vein on the clamp on the vein would be helpful. Here my plan is for inner urography. This is a big defect will be there. To do that, cover the defect, I am using, this is True Barb from Healthium company. This is 26 mm needle and this is 40.
this is a one gentleman and for which actually many options would have been there, I am sure, all of us who are sitting here. And probably as one of the options, he got bilateral RIRS done. These days we are even listening this same technology as it is available has been tried in the infants or maybe the newborns also. So anyway, so this RIRS was done probably 3 months back, and post-surgery, patient presented after 3 months exactly. Patient actually flew from Finland. The parents came from Dubai and they actually had a stricture. We got CT done. There was a bilateral upper aortic strictures about 4-5 centimeter but passable. So we just thought of to do endoscopically. We did stenting. We waited for 3 months. Another we changed, and so maybe up to 9 months we tried. 3 times we changed endoscopically. We thought if it gets settled down. Ultimately did not. So parents were concerned because every 3 months they have to flew down from Dubai and the son has to come from the Finland. So we did bilateral PCN. They were asking for the definitive treatment. We did the bilateral nephrostomogram and it did showed us almost one side 5 to 6 centimeters, second side similar 6 to 7 centimeter strictures. And I think so we thought of to do a definitive treatment. And so this was bilateral. We started doing we had exercise system, so 3 ports were put in the midline, and the side which we started off, the 1 port on this side left and similarly 1 on the right side, and we did 1 side first. The steps were pretty reasonable, but what is most important, what we found out was that on table also, like pre-operatively, similarly the on table also, to figure out actual area of ureteric stricture, because when you will see ureter from the outside, you will always feel this is a normal ureter. It's the same. You don't have much to be seen from the outside that where is the exact location of the stricture. So it is, I think, one of the very important thing that you should really be able to make out. And I think after dissecting above, below, and ultimately we could figure out the area of narrowing, and then we had just sling that, and then we started we have put an incision. Actually we had put the ureteric also inside, so if at all if we need to do any dye study. But I think the important thing was pre-operatively, like as I said 2 or 4 weeks back, you need to really divert the system. Then only you will be really able to figure out if there is a DJ just before the procedure, or even then I think it is hard to really that you won't be really make out. So this you can really see that both the walls are strictured, even the posteriorly very few, just we had put the ureteric and there was a guide wire that we have kept through inside, and then we removed the ureteric, then we have put a stent, and by the time the second team was already working out to get to good length and the thickness, almost 2 to 3 centimeter length and 7 to 8 centimeter length of width and the length of this buccal mucosa. And see, the real beauty probably here of robotic is that you can do very good suturing or very easy suturing, I would say that. So this was absolutely kept, and nowadays I am sure all of us must be seeing that many cases of strictures at different part that we'll be seeing, I am sure, than before, maybe because of the different techniques which are being used probably. And so this is a completely onlay kind of a thing which was sutured on both the sides, and we do this kind of continuous suturing. And this was much more than the actual diameter, so I think you will see that. And at the end, what is been already asked for this partial, we even did this ICG and we just made sure about, and it was reasonable to figure it out, and the last part was also done similarly, and the closure was done. And then Once this was done, we just changed the position, and as I said, 3 ports were, because of the XI are the same, we just had to put another port on the other side, and we did the similar dissections. Yeah, this was, yes, this is exactly done on the other side. Can I, probably, do I have option of fast forward? Because this is a similar technique, yeah, what has been done. Okay, yeah. Yes, yes. So similarly, I think the opposite side, we did the same way. We have just got the graft ready, and then this was already started. We started doing the, it was very well getting above that, and the complete area was, similarly, as I said, on this side also was difficult to really find out first the area of stricture, but once we figure it out, I think this was done. Yeah, so again we did the same thing, ICG, and then we, this was the closure was done. Okay, so this is now 1.5 year almost follow-up, and child is good, no hydronephrosis. And this I am sure we all get these days good enough, like the different level of strictures, like for the lower we do even if there's a larger segment, Boari, and then psoas H, and similarly. And this has been now, buccal mucosa has been, I think we really need a long-term follow-up. We only have a 1.5 year or 2 years follow-up, but probably what happens after 5 years or 10 years would be really interesting. And it is being tried, and I think we would really like to invite everyone for the Lapiro workshops. Thank you. Thank you very much for that.
That is a nice procedure, sir, demonstrated. Thank you. Sir, do you wrap around any momentum?
No, we did not. I think, yeah. That could be.
Had it been one-sided, would you, sir?
Pardon?
Had it been one-sided BMG retroplasty?
Yeah, then we could have, but probably as it was bilateral, we really thought of to probably not do that.
Dr. Shirin,
yeah.
How applicable is this technique for a little distal ureteric stricture? Like mid-ureteric we all understand.
Yeah, in lower I would not try this.
You won't try.
Yeah, in lower already we did twice, we had a like 12 centimeter long, we did Boari. So if it is like you get a good flap from the bladder itself, rather you try to put anything like buccal mucosa or so. So for lower ureter, definitely we will never attempt this. So it is mainly for the upper or maybe up to mid, not beyond that.
So apart from location in your mind, what are the other limitation of this procedure? Is the length of stricture also a limitation?
Yeah, length probably till 7-8 centimeter, maybe I think is reasonable, that is one. But that is what I already said, I don't know about the long-term result. I am not sure whether what would happen down the line, 5 years, 7 years, 10 years, and I don't have follow-up. So I think right now the patient is doing good. So, but I really would like to see, like this is only 1.5 year. We need to see it at 3 years, 5 years, 7 years, how he really remains. So, but my real message is, for a 5 millimeter or 6 millimeter bilateral upper aortic stone, does this really required? I'm looking back to that. Where are we heading towards? Do we really, are there any other better options of, or do we really believe that certain technology has gone and we should never attempt probably lithotripsy and we should have, so I don't know. This is what the actual message of showing this video is, that it is not that I can do robotic, the buccal mucosa. My question is, do we really justify in making the right decision when patient has got the problem, like bilateral 5 or 6 millimeter upper aortic stones? That is my, I think, only questions.
I think to my mind that is a debatable issue, as you mentioned, but of course if one has to do it, probably one has to keep a very low threshold and err on the side of doing pre-operative stenting rather than attempting a primary RIRS.
Absolutely.
Like, patient would always come and demand, and it's a way we have to explain that you are anyway going to require 2 sittings, whether stent first and a removal of stent and the stone later on, versus stone and stent followed by stent removal. It's going to 1.5 days for you.
I still believe probably for this size of stone, anyway, as you rightly said, it would be different views, but I would still say probably lithotripsy for this size of stone may be a good option. But anyway, that's individuals to decide. Yeah, fair enough. right.
Thank you, sir.
Thank you very
Can we
much.
go to Dr. Gautam Soti, AIMS Jodhpur?
Jodhpur team. Please shift to Jodhpur.
He is busy controlling everything. It is not disturbing.
So am I on?
Can we have the video of Dr. Raghu Soti also? SMS. Yeah, Gautam. Dr.
Hi, sir.
Vamsi here, yeah. Good
Hi, sir.
demonstration, yeah.
So you see I have taken this DVC, but I have not cut because after cutting sometime it ooze and it make my field oozy. So I want to just have at this point of time. Before that you could see the endopelvic fascia I have opened, and I want to be very careful on the left side because disease is on left side. But still my extent of the dissection would be when the prostate start taking curve and purely I have reached to the apex. So I see the dilated vessels here, and similarly on the right side looks very good. So I have done this endopelvic fascia opening, no cautery used, and this is small prostate relatively, not very good prostate to do. Usually 40 to 50 gram, I think they are better. And while opening the bladder neck, you could see that by pinching I could palpate, but since post URP it is difficult to solely rely on that where is the bladder neck. So you have to have your mental image that how big prostate was. If it is big, then you should stay bit posterior toward the bladder. If it's small, then you have to take judicious decision because we don't know the how the TRP was done, especially not done at your center. So as D.V. Singh sir said, so cystoscopy can again help here in planning that what kind of bladder neck I am going to have. So that's why. Now I opened, and posteriorly it's very clear that trigon is here and left ureteric orifice. Here should be the right ureteric orifice, and you could see, you have probably have seen that post ERP changes are there, still some slough is there, and I stayed into the bladder rather than trying to make the bladder neck small. I am okay to be toward the bladder. So that's all so far.
Dr. Gautam, good afternoon. Srivatsa here.
Hi, sir.
Hi. So do you always take the DVC control, or do you also consider cold cutting the DVC at times?
No, I always take the DVC control, because I feel it makes my field clear and I am comfortable, but I don't cut DVC at this point of time. I keep it for later.
Okay.
That's my and you could see that I am hopping up and down a lot. It helps me. Right now I am doing 30 down, but when I was doing this cutting even the puboprostatic ligament, I was 30 up. It helps me a lot. So once I tried doing RRP on 0 degree, so I was not very happy. What is your take from the chairpersons?
I think it's a matter of
30 versus
convenience. I mean,
0.
Yeah, people who have been used to SI are more comfortable probably with 0. People using X or XI are comfort because of the toggle that is available. I think they do exactly like how you are doing, and that's probably more easy.
Okay. So here I see that it is coming, even this is the SV and coming this bulk, this tissue is coming posteriorly. So I am happy to take this tissue rather than going very close and toward the prostate and maybe positive margin. So I want to avoid the positive margin, and I often use the cautery when I am not planning this neurovascular bundle preservation. So on this left side I am not thinking of that. So I am using lot of cautery. Probably on the right side I will be preserving the neurovascular bundle. So then I will be using less cautery.
Dr.
Ready with the clip?
Dr. Gautam, PP Singh this side.
Sir.
Good luck. Now coming back to this discussion of 30 degree versus 0 degree. Like I had been doing for quite long with 30 degree. Of late, I have started using only 0 degree. Now, my short experience is in an easy prostate, where the prostate is not very deep and the patient BMI is not very high, the 30 degree, the 0 degree is good enough. Only in cases where the prostate is deep, the prostate dissection is difficult, that is where 30 degree really, because you can toggle from 30 up, 30 down easily. So probably there the role of 30 degree is there. And as far as the anastomosis is concerned, mostly all of us are comfortable doing it with 0 degree.
Okay, sir. So I don't know some problem with the camera or what. Vision also I found good with the 30, at least what we have in our center. So I use 30.
Maybe then you need to get it checked. Like we have had similar.
So I'm happy in taking
both 0 and 30.
Yeah. Give clip to me.
Dr. Gautam?
Okay, apply.
Hello, Dr. Gautam, Dr. Prashant Gupta from Jaipur.
Prashant, take this kind of mic maybe.
Hi, Prashant sir.
My question is, this is the post-URP patient. Do you
Yes,
have
sir.
any difficulty in identification of the ureteric openings? Whether you put the ureteric catheter prior?
Sir, that is the best if you ask me, but I was doing when I started, but now, frankly speaking, not doing. But definitely if you ask me, then I would err on the side of having the CP and this UCAT. No doubt in that.
It will come down, don't worry.
Okay. So you can see here on the left side was my concern of the having disease, and it was going the outside prostate clip, but luckily I could take, probably it should be the negative margin only. Yeah, good. So I now onward, like after this dissection, I prefer to use cautery as low as, or usually not to have the cautery. So let's see how I can do today. So this is the right side SC.
Dr. Gautam will continue to watch you. We'll shift to audio to Dr. Raghunath Saraswati.
Yes. Partially going on there. So yes, please.
Please
shift to Jaipur.
Yeah, take it.
Put this one. Between
Raghu sir, Dr. Vamsi here, sir.
Hi.
Hi, sir.
There was a little bit of bleeding was there.
Yes, sir.
I tried to, even now it is there. This is probably venous bleeding, and can you put this one? I'm just trying to control the venous bleeding first. Let me run again. Be ready to put the betadine to identify where is the ज़्यादा मत डालना
शशांक ऐसे को पकड़ लो.
Raghunath sir,
yes.
When we identify such venous bleeding, have you ever tried unclamping the vein and see, sir, whether the
Yes, we tried. Not in the in this case also I tried.
Okay.
Yeah, fine, very good.
Do you find a benefit at times, or?
Yes. In case some artery is there, small artery which is unidentified, there is no option. No? You block the vein, but artery is pumping. In such cases, you can't identify the artery. In such cases, better to unclamp, so that blood from the kidney will go out. That reduces the bleeding.
Do you routinely clamp the vein, sir?
Most of the cases, yes, but not required all the time.
Okay.
Can you put the betadine? Yeah. So here it is there. Yeah. Enough. So that is the calyx which opened. Suck behind.
Sir, unfortunately your video went off when you were trying to describe the selection of your sutures. Can you quickly explain, sir, what is your choice and why?
Which one, Dakshi?
The choice of your sutures. When you were explaining, your video went off.
This is true bore suture.
Okay.
This is 26 mm.
Okay.
For a large defect like this, it will be very useful to use 26 mm. This is 40 suture. If you use 30 or 20 for inner layer, chance of having AV malformations will be relatively more. So I prefer to use for inner rhinography this 40. Outer rhinography you can use 20 or 30 Stratafix or even VLOC you can use it.
Okay.
The only disadvantage of this is you can't fulgurate next to the suture.
Okay.
So this is heat labile.
Yeah, the suture will give way.
Yeah. So it will give away, it will just snap like Stratafix. That is the only disadvantage. So otherwise, so that is the suture, this one pelvic calcium system.
Now that the bleeding is stopped and the inner rhinography is mostly done, would you also consider releasing the clamp?
To reduce big defect is there, I don't want to. It is just 10-12 minutes over. I don't want to release right now.
Okay.
Agreed.
For small tumors, yes. I will do that.
It's better to control, take little more time in such a complex situation rather than hurrying it up.
I don't worry about time.
Yes.
My timings can go up to even 40-50 minutes.
Yeah, a good rhinography, first time done should be good
Can you
enough.
put some more bit in? Yeah.
So you don't take the pelvic ileal system separately.
See, 2 cc pushed into the pelvic ileal system, there is no leak. Right now, if you are happy, I will just stop the inner rhinography.
Dr. Raghu, Samit this side from Delhi. Would you be more comfortable putting in a stent after you've done this?
Stent generally I don't put.
In a big
Generally I don't
defect,
put stent,
lower
but
pole.
you can, it depends on your individual choice, you can put it. Yeah. No, give me one more Stratafix only. Since it's a hemostatic I did, this is not true. I am going to take another one. Probably this is going to be most important one because lot of bleeding was there. So just to reduce that one, I have taken that. I will run one more layer of inner layer. A large defect is there. You may not agree with me. So pelvic system we have sutured and bleeding is controlled, but when I remove, definitely some arteries will bleed. So I want to make sure the inner rhinography is proper.
Okay. Sir, while we watch, can we just skip over to Raghavan sir's OT?
Any comments? See?
No, sir. Yeah, sir, it's going on beautifully well. Hemostasis has been completely achieved. I think it is just now the closure. Hello? So can we migrate to Raghavan sir's OT, please? Chennai? Raghavan sir?
Hi, Srivat.
Sir, yes sir. Sir, can you quickly take us through what you have done and what is your plan next, sir?
Okay. Okay, what we have done is just let go. Yeah. So we have done the anterior bladder neck. I preserve the bladder neck as much as possible. I am not very pro bladder neck preservation. I do it as much as possible. I then take a stitch and tuck the catheter up. It just gives my third arm freedom for my third arm so that I can do whatever I want to do as a retraction. Then what I did is go into the posterior plane, identify the vas and vesicle, lifted them up. So I take it with one of my arms and Madhav takes it in the other arm. and once we have done that, we identify the plane in which we want to work. It is just so that in this patient I can show all the 3 planes quite clearly. So what we are seeing just here is the extrafascial plane. You can see the fat there.
Yeah.
And then on top of it is the transfascial plane or interfascial plane. We are in the interfascial plane here.
Okay.
And I can go a bit closer as well. Can see the interfascial plane, right?
Yeah, we can.
Yeah. What we do is now we sweep the fascia out, and all the perforating vessels which comes into the prostate, I just do a dot diathermy like that, and then keep on sweeping so that I can get the neurovascular bundle cleared up. I don't use, interestingly, I don't use 1,000 hemologs, which is what generally people use, because I find that hemologs causes more tissue damage. At the end of the hemolog, you have a lot more tissue which get crushed up rather than the dot diathermy. You just diathermy, say for example, I just do a diathermy there, and then I can sweep the whole thing away.
Yeah, nice.
In fact, this, to all credit goes to Gagan Gautam. I saw him doing it and I thought, wow, that's a better thing to do rather than the hemologs that we used to do. So credit goes to Gagan for that. All of us modify our technique in different ways, learning from your peers and seniors. So I learned a lot from Yuraja sir, learned some from Sudhir sir, some from Gagan, some from Sanjay. So I keep learning a lot. Can you see that perforator artery?
Yeah, we can.
So just take the perforator artery down and sweep the rest.
So why, in this case, why did you choose the interfacial plane over the intrafacial, sir? Because it's a very early disease. Yeah.
Yeah, you can go intrafacial straight. Just that it becomes too close to the prostate. Just feels uncomfortable. It's almost like, feels like an adenoma excision. Yeah?
Yeah.
As oncologists, you and me will feel, quite uncomfortable with that plane. That's all. But my teacher, Stolzenberg, is a great fan of intrafacial plane. I used to be very, very scared of that plane. Even today I am.
Okay.
It's more a preference to you, but you can do it. There is, at least technically you can do it. It's just, you can do it. There is nothing wrong with that. It's just that I feel more uncomfortable with that. So, let go, Madhav. Yeah, thanks. So once I think I've got enough, release the plane, then I take over in the hands and Madhav just assists from the posterior, that's all. Yeah, Madhav? So these are that is the curvature of the prostate. You can see the curvature of the prostate.
Yeah.
So whatever attachments are there, we just divide it down with a dot diathermy and then sweep. Can see the curve of the prostate again?
Yeah, we can.
Yeah. See, I do not know, is the vision good from the projection? You guys can follow what is being done here?
Yeah, we can, sir, we can. So, like we were discussing, sir, regarding the system itself, you did mention one disadvantage, but if you could now for this one particular procedure, radical prostatectomy, if you could, tell us 2 or 3 salient advantages or disadvantages of Hugo RAS, it would be easy for the people, who would want to make a choice of this system.
I'm not going to talk about the cost because it is beyond my control and I'm not keen on that. What I would say is that anything that you do, that is the artery that is coming through now, yeah?
Yeah.
We just do a diathermy and take the artery down. So once again, I was telling somebody that this is a total, almost near total clipless radical prostatectomy. So we hardly use a clip during this operation.
Okay. No, regarding the Hugo
regarding the system.
Yeah,
regarding the
yeah.
system. Pull the catheter out, Manu. Yeah. Regarding the system, I will put a simple summary that almost 98% of the things that we ever want to do with prostate, ever want to do with robotic surgery, you can do with Hugo RAS, because the system is reasonably compliant. Yes, when they introduced it first, it was very unstable. It used to freeze all the time. But then after that, they have introduced version 2, which has become far more stable in terms of the instrumentation, in terms of the projection. The downside of Hugo RAS is that it's a laparoscopic 3D. It is not an immersive 3D. And sometimes in a very obese patient, you want an immersive 3D rather than a laparoscopic 3D.
Raghavan, hello.
Yes, sir.
Raghavan, you are
Yes,
here.
sir.
See now,
Yes, sir.
I think probably you are doing a now sparing, right? Or
Yes,
at least something like a hood technique you are doing it because you are going.
It's a combination of what you do, sir. Yes, sir.
Fine. So now, how to explain the clips causing the damage to the nerves when you are close to the prostate? And because we never use any cartridge near to the neurovascular bundle whenever we think of nerve sparing, even otherwise we will minimize it, even in non-nerve sparing, not to damage any surrounding structure. So how do you explain using that
Sir,
this much of cartridge?
Okay, sir. Just one second, sir. I'll just show what happens now. You take this and take it down. See, we know that the lateral neurovascular bundle comes here. Yeah? This is the start of the lateral neurovascular bundle. You want a total neurovascular bundle preservation. So the lateral neurovascular bundle starts somewhere here. Yeah? Now you apply a Humalog clip. You are going to crush all the tissues. A 10 mm Humalog clip will crush everything that is here to here, sir.
Yeah, if you close now, actually before doing that, we release it and make it down, and then we apply the clip. Either you can use Hemoclip. If you are not sure, then we use the normal metallic clip, which is very small. So that's what has been explained. But cartridge definitely at least 5 to 6 millimeter is already damaged, no?
5
millimeter definitely it is damaged. So now it is almost the same if you take the same principle, because if many people are watching it, and for a neurovascular preservation, I think many people don't even use the cartridge and only clip and cut, or you can just cut it and then do a oversewing with the sutures. If it is I think it is very important for us. So because we whenever we do nerve sparing, see now you are releasing it, right? That is fine.
Yeah.
The fibers what you are supposed to cut, they are all just the detrusor fibers going into the prostate. So the tissue which is lateral in your scissors, below the scissor is the area where we have the neurovascular bundle. This you can apply clip and cut. That's what I'm just was thinking about. Ravi?
With the patients that we have done this way, we haven't had a much of problem in terms of recovery, sir. What we find with the neurovascular bundle preservation is the patients who have fantastic recovery of continence on day 1 and recovery of erectile function by month 3. One of my PGs did a thesis on that. One second, I'll just. So what we found is that when we do a neurovascular bundle preservation, this technique, the patients are getting good erectile function at 3 months. So I do not know, sir. The cautery is something that I have done so far. Can you apply the clip here? Just to.
Yeah, Raghavan sir, Ravi here.
Yes.
So
yeah.
a fantastic section.
So what has happened is that the clip has gone here, while I would have released it here.
Exactly.
So I do not know. I just find it. I'm not able to maybe explain it in clear terms, but I just find it that we lose a lot more tissue when we do a cord clip.
No, sir. Instead of this Hemlock clip, you can use the metallic clip. So this is a common problem even
even metallic has a.
It will come straight, sir. This will it will not have this kind of angle. It will just come straight. So more often than not metallic clip is easier to, so just try that, because we've been doing the same thing with the residents trying to apply Hemlock, and it goes, it doesn't go to at the intended site. So metallic clip.
Yeah, it always goes to a place where you really want it not to go.
Yes.
And then we think, oh my God, okay.
So another thing I wanted to ask, there's a recent, it's quite old concept also, injection of saline in the neurovascular bundle to help dissection, and that helps identifying the vessels as well. So have you ever tried that?
We tried it. In fact, Madhav did on many cases. What we found is that once the initial getting the first plane is what it helps, but beyond that, it is just the same. We're able to do the same thing without the saline. So yeah, if Madhav is doing the surgery, he will apply saline. I just don't bother.
So are you suggesting that with some experience you can get away, but in initial phases one should do it, or?
It definitely helps. We find that it creates the plane for you. It gives you that plane where you want to enter. One disadvantage with Hugo Ras is what you are seeing. The progress that works, stop the counter. The progress that works beautifully in Da Vinci doesn't work that well in Hugo Ras. The Cadair is what we get here, but it is slightly more, slightly less powerful compared to the Da Vinci progress. I was being told for the last 4 years that we will be getting a progress, which I have not got it from the Hugo Ras.
Raghavan sir, can we shift the audio to Gautam's sore?
Yeah, please.
Hello Gautam. Gautam, are you there?
Hello. Am I audible?
Yeah, you are.
Okay. So far you could see that I have taken out the prostate.
Yeah.
And since the post-TRP setting, probably the posterior planes were not as I wish, but they were okay. On doing the right side neurovascular preservation, you could see, and I could merge the radical plane on this side and the neurovascular bundle preservation on this side, and you could see that on the right side adenoma was projecting beyond the more toward the pelvic diaphragm, but I could keep it with easily without any confusion. So at the apex I tilt it right and left, and then I could manage to have the good length of the urethra. I am happy with this much length. Usually I don't bother of the length. It should be flush cutting with the prostate. Usually I don't go with the intraprostatic to gain the extra length. So this is the prostate removal. Now I will go with the bladder neck reconstruction, fish mouth on both sides, 20/3. And then we'll go directly with the anastomosis.
Gautam, Yuvraj here.
Sir.
I saw you applying Hemlock clips. So there was a discussion with Raghavan that we should not apply Hemlock clips because it causes, it includes a lot of tissue. So especially nerve sparing. So now my question is that, so you are applying through the robotic clip applicator.
Yes, sir.
So is it necessary, or can we get it?
No, it's like we don't have this large clip applied to the assistant. So usually I apply the robotic and only 2-3 clips. So it's because of habit, not we want to use the robotic.
It's quite expensive, right?
Sir.
It's quite expensive. So
and
I think assistant can easily do it, right?
Yes, sir. Assistant can do it.
Yeah, I think what happens is that many people will be doing the same thing. So you can do in this way, but I think the cost will really go up.
Yeah, yes, sir. I know. But usually we don't apply the clips, like only 2 clips at the neurovascular bundle where from the start.
Yeah,
and
so
then
actually it is needed only at the base of the prostate.
Yes.
3 on each side, 6 clips is equal to 12,000 rupees, right?
Oh. Sir,
Advantages of being in AIMS, sir. They don't need to know.
We don't think in that ways.
No, but Gautam, somebody is praying now. Somebody is praying now.
That's
I think government is praying
this is
now
not
for
the
everyone.
intention.
Yeah.
Because we don't have the large clip applied.
Show the
and-
ureteric orifice. Show the ureteric orifice for everyone, so we know that where it is.
Yeah.
Exactly.
It's a pre-lateral.
Dr. Gautam, 2 points I just wanted to clarify with you. We just saw you go behind the urethra and then, cut the urethra. Many people say, including Dr. Vipul Patel, that the moment you go behind the urethra, you would have, damaged the support of the posterior plate of the urethra, which can compromise continence. What's your take on it?
That's true, and you could see the rectourethral muscle, and I was cutting earlier when I was doing the posterior dissection. I got confused that whether it's some rectal fiber or rectourethral muscle. But since the left side disease was bulky, so I don't want to take any chance. Rather, I am more concerned of not using the cautery rather than dissection. And as Raghavan sir said, it's true that you preserve the neurovascular bundle and you use lot of clips, then yes, I don't know how much we did the justice.
Yeah,
the second, I think what you said is right. So only thing is, when we are discussing at the apex, when we go, there are 2 ways. Either you just cut it, but only thing is, if you don't have a plane between that and the periurethral tissue, then taking a stitch becomes a difficult posterior one. Invariably, you are going to take the stitch through the posterior support, right? When you take the stitch in the posterior wall. So rather than the explanation is that don't go towards the perineum, go towards the apex of the prostate and create a plane below the urethra. So you be close to the prostate, so you are not going to damage any posterior urethral support.
Yes, sir. Because I will not take ROCO even.
Dr. Yuvraj, I just want to ask you, now that we say that the neurovascular bundle is not only posterior lateral, it is there all around. The nerves, it's like a web of nerves all around the prostate. So how much do you think taking a ROCO suture, deep ROCO suture, is going to damage all those neurovascular bundles which you have worked hard to preserve?
Yeah, so what we do is that if you see the anatomy and if you want to try to preserve the neurovascular bundle, 90% of them are on the posterolateral prostate and posterolateral lateral to the urethra. 10% may disperse. So we cannot have 100% nerve sparing. So you have to accept it. So at the urethra, when you take a ROCO stitch, it is not going to include neurovascular bundle at all if you are dissected away from the urethra.
Why I asked you this question was, like in my technique, I was not taking ROCO sutures initially at all. Even with CMR which I was using, I was not taking ROCO sutures at all. The only help which it gives is that it gives you confidence that your anastomosis posterior layer will be tension free and your sutures won't cut through. But looking at everybody is taking now, I have also started it, and I am finding it easier to do an anastomosis, putting a ROCO suture there. But it's not that, like we do not have a case control study to prove actually that ROCO suture would help increasing the recovery in continence of a patient.
No, they have done a randomized trial by ROCO only.
Yes.
The son ROCO, not the father ROCO. Father ROCO believes that. Son ROCO doesn't believe that. He did a small randomized study and he proved that there is no major difference unless all other factors are considered equal. It is difficult to do that.
Very right.
See, so athermic dissection, bladder neck narrowing, and then total reconstruction of the periurethral tissue. Everything is important. I think this is one of them. If you are not compromising on anything, or you are not taking a needle through the neurovascular bundle, ROCO stitch gives you much better. At least surgically you feel better.
Yeah, you feel
everything
better
is being placed in the same place where it was there earlier. That's all for our job, is to make it in similar way. The outcomes, it is very difficult to measure because the confounding factors are so many.
In fact, nerve preservation versus no nerve preservation, do we have actually a controlled study which says that in terms of continence it is better? In terms of continence, we are not still sure that nerve preservation is better in any way compared to non-nerve preservation.
No, they don't have a randomized study, but there are so many case control study, analysis, paid match analysis are there to prove that nerve sparing will be useful along with other factors for continence and as well as pregnancy. But there is no direct
Probably the only factor which maximizes the control is the length of the urethra which we preserve.
Sorry to interrupt the discussion. Can we have 1 minute from Jaipur? Can you hear us in the auditorium?
Yes, yes.
So Dr. Raghunath sir is just completed, and I am handing over the audio to him. So he wants to show us. Raghunath sir.
Hello, hi Raj. Hi Dr. Ravi, Dr. Srivats.
Yeah, tell me.
Can you hear me?
You know, it's a very nice dissection and suturing. What was the warm ischemia time? Audio.
We can't hear.
Yeah, Raghu, can you hear? No, we can't hear Raghu.
Can you do something?
Now we can.
Yeah,
Yuvraj. So it took 35 minutes. I don't go by whether 35 minutes or 45 minutes. Here bleeding was more. I tried unclamping the vein twice. Despite of that, it was there. So I clamped the vein and I continued. The first thing I did, of course, under vision we cut the kidney. Otherwise, sometimes if you get into the tumor, you don't recognize. So under direct vision, cutting is very important, and I had to control the bleeding by taking inner rhinorrhaphy so that I can do rest of the work under proper vision. So it took 35 minutes. I used 2 sutures for inner rhinorrhaphy and 2 for outer rhinorrhaphy. 35 minutes of ischemia time.
Yeah, it's fine, looks fine. Very nice.
Very nice.
Then any comments, any questions?
Yeah, fine. No,
Calls for a big round of applause to Raghunath sir for dealing with such a difficult case.
Well done,
sir.
So excellent anesthesia team, excellent assistants, Seema and Mamta and my colleague Dr. Ankit, and of course excellent here Dr. Neeraj and Dr. Vyasi there. Excellent team, fantastic. Thank you.
Sir,
Thank you.
Raghunath sir, one question, sir. So, retrospective thought, was the vein not fully clamped? So, is that the reason the bleeding was happening? Because you did not dissect the vein fully to start with.
There was another vein which we pushed the clamp posteriorly so that it would compress completely. I checked twice. Despite of that, oozing was there. Sometimes a very small artery may be pumping. Sometimes the small artery may be pumping even if you clamp it or not clamp it. Sometimes the ooze is expected. If you unclamp, it should settle in that situation. But in this case, unfortunately, it didn't settle. So whenever you're doing a hilar tumors, you should be extremely careful to have a proper vision. Many times we do non-clamp. If the vision is not poor, we are going to compromise on the oncological outcomes sometimes.
Raghunath sir, one point that I wanted to bring in here, not for all cases but for difficult cases, or when the angiogram is not very clear, what we do is after we clamp or what we think we have clamped completely, we use the firefly. We inject ICG and then see. Many times actually we have picked up perfusion and we have looked for some more vessels and then clamped it.
You are absolutely right. We did that. See, there was no flow to the kidney. Kidney was completely blank. We did that. We did the firefly. We did ICG. Complete, blood supply was cut off. We did that in the beginning. I don't know whether you
we missed that, sir.
Joined later.
Yes.
We did that.
Okay. A very nice demonstration, sir.
Thank you, sir. Thank you.
Applause again.
Sorry for interrupting.
This is Dr. Vyas. Can you hear me?
Sir?
We'll keep Sajisal.
Hello, auditorium.
Yes, sir. We can hear you.
So I just like my colleague Dr. Neeraj Agrawal to say and introduce the wonderful anesthesia team and the rest of the faculty and the other staff who have helped inside, and after that we'll be signing off. So I'm handing over the mic to Neeraj, please. Hello, good afternoon to you all, and would like to thank Dr. Raghunath and his associate Dr. Ankit for performing such a challenging case effortlessly. Would like to also thank our anesthesia team. Please give a big round of applause to Dr. Anupama.
Thank you so much.
And Dr. Siddharth is also here. I think he's in the other OT. So thank you all. Thank you very much.
Thank you, sir.
With that, we are signing off.
Thank you. Can we go over to Dr. Gautam's theatre for a minute?
Am I on?
Yeah, you are on. Dr. Gautam, one other question that I wanted to bring up was, how do you choose to reconstruct your bladder neck? We saw you doing a fish mouth here. So is it a standard technique for you every time, or do you alter it between posterior tennis racketing, anterior?
I am not, your voice is not clear.
Are we audible now? Are you audible now?
Bit better, not. But okay, you asked me that I am doing bit different. Is it some standardized or what?
No. How do you select the type of bladder neck reconstruction that you do? Is it a standard fish mouth every time, or do you?
Standard fish mouth, almost all time.
Any opinion, sir? Yuvraj sir? Dr. Tushar.
Okay, I'll answer that first question first, and then I'll give the comment that I was talking about. For fish mouth versus posterior racket, if the UOs are very close to the bladder neck, then I do a posterior racket so that it takes the UOs away from my anastomosis side.
Correct.
If the UOs are far away, then a standard fish mouth on both sides is fine.
Yeah,
so generally we do a standard fish mouth, but sometimes we need a posterior racket also when the UOs are close.
Yeah.
I wanted to make a comment. Gautam sir, Tushar here. Beautiful dissection.
Yes, hi Tushar.
Hi. Beautiful dissection, and I agree with you about the nerve spare, that clip and cold cut. I wanted to talk about the clips. If generally what I've experienced is, if you're doing a nerve spare, you just need one hemolock on both sides for the prostatic pedicle. Once that's put in, then cold metal, no bleeding, and then all you need are the small metal clips put and cold cut. If you're doing a wide excision, then as sir said, 3 clips on both sides, and that should be fine. But I feel if you're doing a nerve spare, clip and cold cut is what the standard teaching has been.
Yep.
Yeah,
So I'll do
point
LT.
well taken. So just one additional point that I want to share here. We have stopped using metal clips for a different reason. We have started using hyphen therapy in patients who continue to have urinary incontinence. One of the contraindications of doing hyphen therapy is a metal clip in the pelvis. So we have kind of, this is just a...
what is that therapy, sir?
Hyphen therapy, it's called as a MCELA chair. It's a high intensity focused electromagnetic wave therapy. The patient has to just sit on the chair for 30 minutes, and the chair delivers electromagnetic waves which can stimulate the muscles equivalent of around 11,000 Kegels in a short span of 30 minutes. There are several papers which have now shown that over a period of 6 to 8 sittings done once on a weekly basis, the bulk of the external sphincter increases by almost 33%.
Oh wow.
Yeah.
That's
So the hyphen therapy was actually originally described for enhancing the sexual ability, basically a sexual wellness kind of a treatment, and this was an incidental finding. We have been using it for more than 1.5 years now.
Okay.
And in patients who have had long-term incontinence also.
Long-term is, which patients do you offer this?
So patients who have been leaking for more than 6 months.
6 months.
Yeah.
And then you start off.
Yeah,
And
we
what-
start
and
off.
your experience, if you have any, you've had
Yeah,
good
we have
results?
very short-term experience, more than 30 patients.
Okay.
Almost 25 or 26 patients have become dry.
Oh.
So how many
So we
equipments are available all over India there?
Sir, it is I think the chair costs about 40 lakhs.
Okay.
In Bangalore, we have it in about 3 or 4 centers. We just refer them there.
Okay.
I don't want to invest on it because I don't want to be sounding that I am giving lot of incontinence.
So you could see that instead of ROCO,
the rapid patients.
Yuraja sir wants to know what's the cost per patient, sir, for that therapy? Extra cost?
So 8,000 rupees per session.
Per session.
Per
8,000.
session,
And
6 to
average-
8 sessions.
6 to 8 sessions. Okay.
Not bad actually.
Yeah.
Sorry for interrupting in between. We can have the third set of chairpersons, and thank you, distinguished chairperson, for a very nice discussion insightful discussion on nerve sparing and prostatectomy, and thank you so much. May I request all of you to please come to the center of the stage. We can have a group photograph, and then we'll have the next chairpersons.
Shashank, till you change the chairpersons, I want to just put my thought that instead of ROCO, after taking that posterior two most suture, then I put the progress at the bladder, and I took the bladder to towards the urethra, and I could easily, complete the anastomosis. So I don't use ROCO like.
Thank you, sir. Sir, you will be seeing you, sir. We'll be having a semi-live video now.
Yeah, please go ahead.
Yes.
Go ahead. छोड़ो आज तो लेने दो.
Thank you all. May I request the next set of chairpersons? Dr. Amlesh Sheth is here. Dr. Amlesh Sheth, sir, if sir can come to chair this session for us. Dr. Anant Kumar, sir. Dr. Ajay Kumar Sharma, sir. Dr. Dharmendra Gawal, sir. Dr. Kinju Adhikari. Dr. Krupavani. And Dr. Umakant Dutt. May I request the distinguished faculty to please be on the dais for the next, sharing the next session. And we have 4 cases lined up, semi-live videos. We had one very nice presentation by Shanik sir. May I now request Aditya Pradhan sir to present his talk. It will be a 10-minute talk, and we'll be seeing Gautam sir in the next OT simultaneously. Thank you.
Dr. Prithpal.
At the outset, I'd like to thank the organizers for giving me an opportunity to speak on this. So this is nothing very great on the XI system, right? So you had plenty of data, seen many videos of thrombectomy on an XI. But we are the minority. My hospital has a Hugo, some of the surgeries you have seen. Now, traditionally, when you're doing a new platform, you tend to go slow. You start working on simple cases, do prostate, you do bladder a little later, and so on and so forth. But when we do IVC thrombectomy, we are going up the scale of the difficulty. We are the first center to have done this and have reported it, and I'd like to show you one such case. So can you go back, please? Can you go at the beginning of this video? Can you go back a little bit? Can you go to the beginning, please? Can you start at the beginning?
Anand sir, can you please be us with the dais, sir? You are not the chairperson for this session. Thank you very much, sir.
Audio video team, can I have the video at the beginning?
AV team, we can start it from the beginning. Sir wants it from the first second. Yeah.
Yeah, thank you. So like I said, this is the first reported case. So here's an index case on the right side, a 46-year-old male who was a known smoker, and if I can show you, this is the level of the thrombus going about 4 centimeters up. So standard mobilization at the beginning, we are using 4 arms, one retractor for the assistant, and we don't have as yet a vessel sealer device, so my assistant has a ligature with him to help me along.
So, regarding patient positioning, what was the patient's position?
Standard right kidney position as you would do in a XI, but the docking, the instruments go a lot more lateral than what we docked when I use the XI.
Lateral?
The camera is a lot more lateral. It's almost at the mid-clavicular line. And because there were a lot of collaterals which are big and chunky, the ligature was actually quite important. And this we have seen in the most of the times when you deal with these bulky collaterals which are part of the IVC thrombus complex.
So did you control the artery in the interiotocaval area, or did you go?
So, we're coming to that. I'll just be showing you this. So yes, interiotocaval, yeah. So as you might see, many of you have done it on the X side. This is no different. The only thing is your movements have to be a lot less than what is our experience on the XI. The cautery is beautiful. The scissors works lovely, but you need to go up close and to get the clarity of the field. So these lumbars need to be controlled and clipped and divided as always. And here we are going now behind in the intervertebral region. So we've taken control of the left, then the lumbars. Yeah, that was the one of them. So as you can see, it's no different than the feel and the vision that you get on the XI. In fact, the vision is a little better because we are using here a 10 mm scope. So with this, actually, we have fully lifted up the IVC, and now we control the infrarenal segment, and then go up and start mobilizing the liver of the suprarenal segment. So we use the drop down to confirm that we have gone high enough, and we need to control the short hepatics which are there to lift up the caudate lobe. So once again, we confirm that we are above the level of the thrombus, and then we are more or less completed our isolation. So that's the clamp off of the isolation of the segment of the IVC, and then we open the cavotomy. And then we managed to get the thrombus off. Thankfully, it was not inherited, infiltrating into the IVC in the posterior wall, where it was easily lifted up. I used a standard 4-proline to close the IVC. I did not use anything else. We started off from the cephalad end and then come down, and then finish it off with using a ureteric catheter to flush off the lower end, and then close the remainder of the IVC.
Beautiful video, but I didn't see the arterial control. Maybe I missed it.
Yes, I had shown it actually when we divided it.
Just one clip in the artery?
No, LIGA and hemo 2 above, so 3 clips.
Because once you control the artery, then all these collaterals, they become kind of...
Yes, they do reduce to a certain extent, and then we closed off the jutting open of the renal vein so that we don't spill the tumor thrombus around too much, and then whatever else was left for the dissection, we completed that, and then bagged the specimen. So on the Hugo-Ras now, my team, we have done 3. We have done 2 on the right side and we have done 1 on the left. All were level 2. And we were able to successfully do all these 3 cases. So The point we were trying to present was, yes, even with these other platforms, we can perform reasonably complex surgery with good results. You need to have your team in place, your drills have to be set up, and you can manage it as well as at the XI.
Yeah, Pradhan, it was a very good demonstration. But one advice, like I tried to do it, once thrombus should not remain exposed because this pneumoperitoneum is going on and these malignant cells might. So what I do once, as soon as the thrombus is removed, if it is remain attached to the vein, I take a gauze piece, put it there and tie with the silk so that at least it is covered. Or if it is loose, then immediately put into the bag that part and then put a clip over the renal vein so that the thrombus is not exposed to the pneumoperitoneum to the minimum extent. So, because
I get your point, sir. In fact, that was why I tried to suture it, because we were not somehow not able to get that.
Thrombus was lying below or something.
It was lying there. Yes,
Yeah,
yes.
so that's
I get your point. Yes.
That's what the advice I want. Otherwise, you did a very great job. And for level 2, it's very simple. Situation is start worsening or becoming difficult when you go to the level 3 onward.
Yes.
Yeah.
So actually, when you start and on this platform, there is no described procedure. Nobody has done it. So for us, it was a learning as we go along. So I am not going to say that it was easy, because your whole team has to go along with you, and you need to get your drill set right. So this was in fact, my third case. In the first and second case, we really struggled to get everything in order. But now that we got a little benefit of the experience, yes, as you're saying, we can go up more on the complexity ladder.
One question. Sir, very nice demonstration, sir. What is your take on IVC filter preoperatively in such cases?
So the filter, actually we would consider if it was a loose floating thrombus with a good lumen around it, which is likely to embolize. We didn't have it because here, as I showed you in the video, it was fully covering the entire lumen of the IVC. So if there's a lot of flow along the side, so indicating it's a free floating thrombus, probably there I would have our cardiologists look at the option of putting the filter. The second is that if there's a bland thrombus which is tending to go up, that's the case, and I have used IVC filter preoperatively. Otherwise, I have not used it.
But this is a good question, I can tell you. Filter is a real problem for the robotic surgeons. I had a level 3 thrombus, there was a filter. So we mobilized the liver, everything. I could not go beyond that because then that is the limit, and filter is lying there, and I can't remove the filter because I could see few flanges were even outside the IVC. So we put this tape, silastic tape, vascular tape, pulled it, put 2 bulldog clamps, but because of the filter it was not completely obliterated, and during surgery there was blood loss was going on, and that made the at least patient, we could finish it, but patient had a significant blood loss. That is the reason, because it could not obliterate, and I can't remove the filter because filter few edges were outside the. So whenever there is a filter, then one has to be very careful.
And as such, the tumor thrombus do not embolize. Only the bland thrombus embolize.
That is not true.
Yeah, no, generally they are quite tough. I have never heard of it. Actually, never seen.
No.
It does?
What do you feel?
Maybe.
I can't hear you. So if I have
any specific difference which you felt with Hugo for this IVC thrombectomy as compared to the
so yeah, when we did them on the XI versus doing on the Hugo, the 2-3 major differences which you will find. First is you don't have you don't have a vessel sealer on the Hugo. You're totally dependent on the assistant. Then we don't have Firefly. Right, so if you ever contemplating all those ancillaries, you do not have. In fact, we don't even have Tile Pro. So when I showed you the drop-down probe, you need to have a big image of the ultrasound screen facing you to see what you're doing. So these are some of the drawbacks when you're working on the Hugo, but you have to work your way around it, and then you can do it.
Pradhan, don't worry about vessel sealer. It is so expensive. One use costs 70,000 rupees, so we don't use vessel sealer. We just put your clip like that, just because it is so expensive.
Yeah, Dr. Pradhan, I think that's here, Yuvraj here. So I think very nice video in Hugo. It's very difficult to do this case with a Hugo system. I think it's very nice. So as far as the filter goes, as Dr. Sir told that, so filter we never use it. So it is going to cause more harm during surgery even in open case, we had one open case, we could not apply any clamp because there is no space. Filter is very long. It is not a small one. Long with the pointers going out of the IVC, if you clamp it, it will tear the IVC. So usually we don't use it, but tumor thrombus still can go. It is not like it cannot go. We have lost patients, especially as Dr. Pradhan told, if it is a tapering one, be careful. So in tapering one, in fact, I don't do robotic only. Because if it is a round one, then only I'll do it. Tapering one, I'll go for open only, so that I go beyond the thrombus, above the liver, control it, and then do it.
In fact, Dr. Yuvraj, I might add one point. The one time when we found it beneficial was when there was a big bland thrombus almost reaching to the ostium of the renal vein, and then there was a tumor thrombus amount, there was a gap. That's where it helped. And then post-operatively, the cardiologist pulls it out from an IJV approach and just pulls it up antegrade, and then
Which
it comes
one?
off.
The
cage.
If you think that it is a very
Then you
small
can get it.
thrombus
That
near
you
the renal vein, it floating, it may go off. Then you can. There is a lot of space there.
Yeah.
If there is a space between the thrombus and the filter to apply for the clamp, it is fine.
That's what is important.
So that is very rarely required. So, but tumor thrombus still can go up and cause, and we have lost patients also.
Sir, if preoperative imaging has suspicion of infiltration of the wall of the IVC, then how do we approach it, especially if the lumen is...
Yeah, so that is a problem, because here is a question of how much of IVC is infiltrated, and that is something which you will not really be able to judge very accurately. You try to, on your CT images, to see how much is the infiltration plane. If it's just small diameter, 2 or 3 centimeters in one case, we have cut it out and primarily sutured it. But there's a big defect requiring a patch. I think I would not do it robotically. I would go open.
Correct. So now IVC wall infiltration, 2 types, partial or total. In total, invariably the segment below the thrombus has got completely thrombosed and it is not working. Already collaterals have been developed. So we don't do anything, we just cut off it. So IVC we don't reconstruct. Partial infiltration, then we do a patch. Complete reconstruction is very rarely required.
So I would...
Even if you don't know whether it is some part is because either you missed it, but while you are doing it, thrombus which is not coming out, just cut it. And even if you leave little bit of IVC, that patient will have post-op edema and all that, but within 6 weeks you will see that everything disappears and they become all right.
Sir, in a few cases, we have actually, for the right-sided tumor, we have just transected the IVC and left it, sir. Nothing much happens.
Yeah.
Yeah, so I think we can, for a right-sided tumor, it's pretty straightforward. Especially a bulky thrombus like this would have already occluded the left renal vein, collaterals would have already developed. We have done it several times without any major consequence.
I remember long back in 1990, doing right radical nephrectomy, there was a bleeding, and the bleeding kept on going worse. So finally, lot of sutures were put and total obliteration of the IVC. The patient who did not have any thrombus. Post-op patient have lot of edema and all that. We thought that we'll put a graft and all that. But slowly we saw that everything is disappearing at 6 weeks, nothing. The patient became all right.
In fact, the guideline is that if there is a bland thrombus distally, IVC should definitely be transected and either stapled or sutured, because there is no point taking out a bland thrombus. The bland thrombus will form almost on the table. It won't take any time to reform, and there will be a very high risk of pulmonary thromboembolism later on. So if there is a distal bland thrombus, IVC has to be transected and sutured.
So this about the cable wall infiltration, I personally feel that it's an over-reported, probably overhyped thing also. I think a lot of these situations, first of all, I'm not very sure how reliably any imaging can say that there is actually an infiltration and what is the patch of infiltration which is there. I think it's a lot more speculation than actually seeing what happens. It's a very, very intraoperative thing. And the second thing I feel more from open surgery, I haven't done robotic IVC thrombectomies, but from open surgery what I can say is that it is the landing in the wrong